Okay, thank you. My name is Jeff Delaney. I'm the Division Chief of Pediatric Cardiology at Children's Nebraska and Nebraska Medical Center, and I am an interventional pediatric cardiologist. Today, I will be discussing the relationship between KCNT1 and the development of life-threatening arterial to pulmonary artery collateral blood vessels. There is very little literature currently published on this phenomena, which occurs in a small percentage of children that have this genetic defect. But when it happens, it is profound and life-threatening, associated with heart failure, respiratory symptoms, and eventual development of bleeding in the airway that can be life-threatening or life-ending. So we needed to make the community aware that this is a possible consequence of their disease so that they can be vigilant and reactive to the best of their ability if they see signs and symptoms. So there's a congenital heart defect that is associated with what is called MAPCAs, or multiple or major aortopulmonary collateral vessels. And these are vessels that are abnormal, but they replace the normal pulmonary arterial tree. And those can be surgically reconstructed to correct that lesion. In children with this genetic defect, they have their normal pulmonary arterial tree, and these are extra blood vessels that grow from the aorta or the branches off the aorta to the lungs and provide an excessive or additional amount of pulmonary blood flow that can then encircle the airway and cause bleeding. So these provide problems in a number of ways. The most obvious of which is that they provide a volume load on the heart, and the heart can become dilated, you can have diminished function, and the child can have respiratory symptoms as a result of just volume loading from excessive blood flow into the lungs. And that can be treated with diuretics and medication, but unless you can do something to reduce the volume load, you won't correct the problem. The other concern is that the arteries appear to be abnormal. The limited literature we have has some pathologic specimens of the arteries that show abnormal wall structure and thinning of the blood vessel that could make them more likely to rupture and cause bleeding. With both of these problems, the treatment is to remove as many of the collaterals as possible to restore a normal volume load to the heart and reduce the risk of bleeding. And that's done with a catheter-based embolization procedure with a variety of embolization techniques, including coils, plugs, and embolization material. So any child with this genetic defect that has bleeding in the airway, even if it doesn't seem significant, should be evaluated. I was surprised, and I think it's important to note that some of the children that are reported in the literature had contrast-enhanced CAT scans that did not show the vessels as well as you would have liked. So I think if there is a high suspicion for this, the best test and the gold standard is angiography in the cath lab, and that also gives you the ability to treat it at the same time. So I think any child with airway bleeding should be evaluated. It does not occur universally in this genetic defect, so unless you have other cardiac symptoms or bleeding, I wouldn't think you would need to do it routinely. But if you have either of those things, you need to do it because the next episode of bleeding could be an emergency. The mechanism by which this genetic defect is related to the production of abnormal blood vessels, excessive in the copious, abundant nature that these occur, is not known. Whether it is related to the known channel defects that are related to the epilepsy, or whether it's related as a consequence of the epilepsy to ongoing hypoxia throughout the day that causes stimulation of angiogenesis, which is the production of additional blood vessels, is not known. And I think research needs to target how this relationship occurs, and then obviously what can we do to treat it to prevent the expansion of these blood vessels to prolong life. Okay. So this is a child who has this genetic defect, who presented with airway bleeding, and we took her to the cath lab to explore and intervene on her collateral blood vessels. This is a frontal view of an aortic angiogram, and in a normal child, you would only see the aorta and the blood vessels from the aorta. What you can see, even if you are not used to looking at these pictures, are all of these secondary blood vessels, which are tortuous and plump, going into both of the lung fields, and those are all abnormal and are aortopulmonary collateral blood vessels that are providing a volume load to the heart and circling and laying directly adjacent to the airway, where an erosion or a rupture into the airway could be life-threatening. So this is a flat plate chest x-ray done the day after the intervention that shows intervention on a large number of collaterals with both an assortment of platinum coils, and if you look closely, these double density radio-opaque markers are all vascular plugs that have been deployed in additional spots where occlusion needed to occur.